Inflammatory bowel disease is divided into two types, including the Crohn disease and ulcerative colitis. And it's important for you to know the feature of each of these disorders. Now, at the beginning, once you look at this table, it looks confusing. But here I'm going to provide you with a memory aid, walk you through that, and then after that you will see how easy it is to memorize the features of each of these disorders. So the memory aid that I have for you is called Big C. And that is for Crohn disease. So C stands for Crohn disease. And then big has two meanings. One is that it's so big, this disorder, that it affects the entire thickness of the GI wall. So it causes transmural inflammation, or in other words, it affects the entire thickness of the GI wall. As a consequence of which, since the entire thickness of the GI wall is affected, there is an increased risk of developing fistula. And it depends on where the fistula is. If there is a fistula between, for instance, the intestine and the bladder, then there would be air in the bladder. On the other hand, if there is a fistula between the intestine and the vagina, then there would be fecal matter in the vagina. And then if there is fistula, for instance, in the perianal area, then there would be perianal pain. Now, there is also one other meaning to the big, and it's so big, this disorder, that affects the entire length of the GI tract. So from mouth to anus, any area can be affected, but it's more commonly seen in the ileum, and almost all the time it spares the rectum. Now, as for the other letters, B stands for bacterial. So Crohn disease is thought to develop as a result of bacterial infections, and in fact these patients test positive for anti-Saccharomyces cerevisiae antibody. I stands for ileum, which is the most commonly affected site in the Crohn disease. G stands for non-caseating granuloma. And then finally C, in addition to Crohn disease, it stands for cobblestone appearance of the mucosa. So what happens is that there is focal ulceration of a GI tract, but then adjacent to those there is normal mucosa. So once you look at the mucosa in the patients with Crohn disease, it has the cobblestone appearance. And so this is the other feature of Crohn disease, where there are skipped lesions, where you will have a normal tract, and then after that there would be diseased tract, and then again it would be normal. So there would be skipped lesions seen with the Crohn disease. Now, as for the symptoms in these patients, since the ileum is affected, therefore there would be pain that is usually right-sided. There is also, since B12 is absorbed in the ileum, there is decreased absorption of B12, as a consequence of which there is macrocytic megaloblastic anemia. There is also decreased absorption of fat, so there would be decreased absorption of fat-soluble vitamins like vitamin D, vitamin E, vitamin A, and vitamin K. And then in addition, there is also decreased absorption of bile salts, as a consequence of which these patients develop diarrhea. Now, one other important feature of this disorder is that there is increased risk of oxalate renal stones. So what happens is that normally calcium will bind to the oxalate. But then in patients with the Crohn disease, since there is decreased absorption of fat, there would be accumulation of fat in the GI tract, as a consequence of which now calcium will bind to the fat, and so oxalate will be now free to absorb. So therefore, there would be increased risk of oxalate renal stones in patients with the Crohn disease. Now, the next condition is ulcerative colitis, and the memory aid that I have for you is called UCRAP. So U stands for ulcerative colitis, C stands for cancerous, as well as continuous. So these lesions have higher risk of developing cancer compared to the Crohn disease, and then the lesions are continuous. So remember how I said with the Crohn disease there are skipped lesions, so with ulcerative colitis there are continuous lesions. And then ulcerative colitis only affects the colon. So remember, Crohn's disease was affecting from mouth to anus. The ulcerative colitis is only affecting the colon and more commonly is affecting the rectum. Now, A stands for autoimmune. In addition to the crypt abscesses. And then we have P, which stands for perinuclear anti-neutrophilic cytoplasmic antibodies. P also stands for primary sclerosing cholangitis, pyoderma gangrenosum, pseudo polyps, as well as lead pipe appearance of the colon due to the loss of hostra. Alright, now that we are done with the memory aids, we can go through them one more time. So with the ulcerative colitis, U stands for ulcerative colitis, C goes for cancerous and continuous, R stands for the rectum. So since the rectum is more commonly affected with ulcerative colitis, these patients usually present with left-sided pain. Underlying cause is autoimmune, and there are crypt abscesses that are seen in these patients. And then finally, P stands for pyoderma gangrenosum, primary sclerosing cholangitis, pseudopolyps, lead pipe, as well as P. ANCA. And then for the Crohn disease, where C stands for Crohn disease, again we have B, which shows that there is transmural inflammation, as a consequence of which there is increased the risk of fistula formation. It can affect anywhere from mouth to anus, more commonly affects the ileum, and it usually spares the rectum. Now, B stands for bacterial, so it's thought to be bacterial causes that is leading to Crohn disease. And in fact, these patients are testing positive for anti-Saccharomyces cerevisiae antibody. Ileum is most commonly affected. Now, since the ileum is the site of absorption for fat, B12, and bile salts, since bile salts are not being absorbed, now these patients present usually with non-bloody diarrhea versus ulcerative colitis, which is bloody diarrhea. Because of decreased absorption of fats, there is also decreased absorption of fat-soluble vitamins like vitamin D, E, A, and K. There is macrocytic megaloblastic anemia from decreased absorption of B12. And then finally, oxalate renal stones can develop in these patients. G stands for granuloma, which is non-caseating. So do you know what is the difference between caseating and non-caseating granuloma? And the answer is that caseating granuloma, which is seen, for instance, in tuberculosis, there are dead cells at the center of granuloma, versus the non-caseating granuloma, there is no dead cells inside. So patients with Crohn's disease have non-caseating granuloma. And then finally, C stands for cobblestone mucosa, and these patients have skipped lesions. Alright, now that we are done with these memory aids, you will see how easy it is to go through these disorders. So Crohn's disease is thought to be in response to the bacteria. It's usually causing non-bloody diarrhea and is affecting the right side of the abdomen. Ileum is the most common location and usually spares the rectum. There are skipped lesions where there are alternating normal and abnormal mucosa. It affects the food thickness of a GI wall, and then there are cobblestone mucosa. There are also non-caseating granuloma, perianal fistula, as well as oxalate renal stones that can develop. The risk of colon cancer is slightly increased in these patients versus markedly increased with ulcerative colitis. And then finally, there are some extraintestinal manifestations like migratory polyarthritis, erythema nodosum, uveitis, as well as ankylosing spondylitis. And then these patients test positive for anti-Saccharomyces cerevisiae antibody. Now, one other point I didn't mention is that smoking usually increases the risk of Crohn's disease while it's protective against ulcerative colitis. So you may actually encounter some patients that say, you know, I was perfectly fine when I quit smoking. That was the time that started to develop bloody diarrhea with the diagnosis of ulcerative colitis. Now, let's go back to the table and go over now the features of ulcerative colitis. So it's autoimmune. causes bloody diarrhea with the left-sided abdominal pain because it's usually affecting the rectum, and then it's only affecting the colon, versus Crohn's disease, which can be from anywhere from the mouth to the anus. And so actually colectomy would be one treatment that can be used for patients with the ulcerative colitis. Now the lesions are continuous, and then there are pseudopolyps as well as lead-type appearance of the colon due to the loss of hostra. There are crypt abscesses due to the accumulation of neutrophils. These patients are at increased risk of toxic megacolon as well as colon cancer, and then they test positive for perinuclear antineutrophilic cytoplasmic antibody. They are also at increased risk of primary sclerosing cholangitis as well as pyoderma gangrenosum. And then smoking protects against ulcerative colitis. So here I'd like to show you some images for the ulcerative colitis. So here is an example of pyoderma gangrenosum, where you can see that there is neutrophilic infiltration of the skin. Here is an example of the neutrophils that is inside the crypt. So here is crypt abscesses that I told you about with the ulcerative colitis. And then because of the loss of hostra, here you can see in this side of the image, you can see that the colon has a lead pipe appearance. And then the final feature is primary sclerosing cholangitis, where there is inflammation and fibrosis that causes alternating stricture and dilation of intrahepatic or extrahepatic bile ducts. So here the resolution is not that great, but there is actually stricture and dilations. And here you can see better. There are strictures and dilation of the extrahepatic bile ducts. And so actually on the endoscopic retrograde cholangiopancreatography, you would be able to see that there are beading pattern of the bile ducts with the primary sclerosing cholangitis. Now the lab values that you will see in these patients, because the bile duct, the extrahepatic bile duct is affected, there is elevated alkaline phosphatase as well as elevated gamma glutamyl transpeptidase that is seen in these patients. Now these patients, 50% of them are usually asymptomatic, but then the other 50% can develop, for instance, fatigue and pruritus. Alright, now we are done with the features of these disorders. Now let's go through the treatment options that are available for both of these disorders. So patients with Crohn's disease can be treated with corticosteroids, or you can provide them with the immune modulators. So immune modulator, like for instance methotrexate and azathioprine. And then you can also treat them with the TNF alpha inhibitors, like for instance infliximab and adalimumab. Now the treatment for the ulcerative colitis is slightly different than Crohn's disease, and the reason for that is that some medications here work better than the other ones. So there has been modifications in the treatment options for ulcerative colitis. For instance, 5-aminosalicylic acid, which is the same structure as aspirin, is more effective than corticosteroids. So these patients are treated with the derivatives of 5-ASA, which includes the sulfasalazine and mesalamine. And how these medications are thought to work, since they have the same structure, similar structure to aspirin, they would destroy the lining of the GI tract, and thus they would prevent the interaction of the GI cells with the immune cells. At the same time, they will also decrease the inflammation. Now, methotrexate is not really efficient in ulcerative colitis, and there are controversial results, so therefore 6-mercaptopurine is used instead. And then finally, azathioprine, infliximab, and adalimumab are the same treatments that could also be used for the ulcerative colitis. Now, since ulcerative colitis is only affecting the colon, then colectomy would be an alternative treatment for patients with ulcerative colitis. And that concludes our discussion of the inflammatory bowel diseases, which includes the Crohn's disease and ulcerative colitis.